you had some very challenging patients early on.
I might begin first by talking about a man called Jute, who was a young Mon boy. The earliest case of major surgery that we did was done in that clinic on that homemade table. We didn't have proper screening. We had people looking in while we did this. I did this under
Curious relatives looking through the window.
That's right.
Yeah,
And
open window.
Nurse Winnie Dodge and I helped. We sterilized up. We had a pressure cooker sterilizer.
Yeah.
And I knew that this, you could see, the diagnosis was easy because you could see the wave of peristalsis from this enlarged stomach trying to squeeze food through a gastric restriction, undoubtedly because of chronic ulcers from all the duodenal ulcer that he had had with stress and high pepper food and all for a lifetime. But anyway, he was gradually starving to death, and I knew that if I didn't do something, he would die. And so we decided to try something. I was fresh out of surgical training and hot to trot do some surgery, and I was working in a small clinic without any proper equipment, but we were going to do what we could do. And so we used spinal and local anesthesia. It was kind of high up for a spinal block. I made a small incision into his abdomen, found a loop of bowel, jejunum most likely, hooked the loop of bowel into his stomach, did a lateral anastomosis, opened it up, and closed up. And it worked like magic because he immediately began passing food through his stomach that he hadn't done for a long time, and pretty soon he had gained 20 to 30 pounds and gotten his health back, and he actually involved him helping us eventually working at the hospital. And I've said he was kind of like a walking advertisement because everybody in the village knew about Jute dying as it was, and there he was walking around doing well. So and having that happen before we even had the hospital going was kind of a fun part of his story.
I think there was another case that you did early on, rather nerve-wracking. Can you tell us about that?
Is that about the man who? No, they owned the burr case.
Yes.
Yeah, there again, that was before we had hospital, and we were called. I was called to see this young man who was laying unconscious on the floor at a house on a Lainam side of San Claverie, not far away. And I had to go up a rickety ladder onto the floor of the house, and there he was. And I examined him, and I could see he had a dilated pupil on one side. And his story was he had fallen. He was a mahout of an elephant boy, and had fallen off the elephant on his head, had struck his head, and had been unconscious since that time. He clearly had an intracranial bleed of some kind. And of course, I again was gung-ho young doc, wanted to do things, and I knew that if he had a subdural hematoma, and I could do a small burr hole, which is not a very big procedure, it might be life-saving. And so we determined to do that. And we got materials together, and I didn't have a proper medical burr, which importantly has to be round, and so that once you penetrate through the skull, you don't plunge into the brain with your drill. But I had an old-fashioned wooden bit and a hand crank, and we sterilized those up, and materials, and we didn't have to do any anesthesia because this man was unconscious, but we went to the house, his little hut, climbed up, set up a Coleman lantern. By that time it was getting dusk, and made a small incision. Of course, again, we had family standing around, and this was rainy time, and there was a termite hatch out. I remember termites flying into the wound and trying to do something for this young man. successfully making a burr hole in the proper side based on his blown pupil, and unfortunately finding that he did not have an external subdural hematoma, but had some form of an intracranial bleed or swelling that resulting in his dilated pupil.
And all this took place in his house.
In his house.
So a house call
a walk away,
for neurosurgery.
Quite about half a mile walk away from where we were. And then I'm thinking again early on, oh my goodness, this is going because he didn't recover. In a day or two, he died. And I'm thinking, well, what must these villagers think about this weird Western doctor using these weird pieces of equipment on the brain of this boy, and he died, look what happened. But the attitude seemed to be more like, well, this is probably one of those outcomes of modern medicine, but it's still better than what we had before. Mm-hmm. At least that seemed to be the way it was, because we certainly had no change in how our busyness kept growing and growing as we got going.
Well, they could see you had done your best to help the patient, and
I hope that's what they felt. That seemed to be right.
So tell us now about the man with the bear bite.
Oh, that was after we moved in and got going after '63, and I had a man. Everybody came with their own convenience, and often they would come by dugout canoe. And we saw and heard that there was a canoe with a man in a bad way coming up the river, and so we went down to see what the situation was. And here was a man who eventually it turned out he had been in a confrontation with a sun bear, who, according to his story, the bear got his whole head in his mouth, and they were on the riverbank. And they rolled down together into the river, and when they hit the water, the bear let go. And this man had a severely fractured jaw, so it was so loose that his tongue would drop back, obstruct his airway when he was sitting up. So he was kneeling on hands and knees in the dugout canoe as they rowed him up. And of course, he had lost a tremendous amount of blood. And
so he was on all fours, so his tongue would fall forward and open up his airway.
That's right, and I determined there was other injuries. He had multiple lacerations, and his face was terribly torn apart, and it had this fractured jaw. I was able to, with some local injection, put wires that wire his jaw back together again, and did some beginning repair of the major lacerations. We were able to give him a unit or two of blood, and I called and had the Thai Army helicopters were willing to take him to town, and he ended up actually at the Bangkok Sanitarium Hospital.
To town meaning big city, yeah.
Yeah, and I'm not sure whether they went to Bangkok or whether they went to Kanchanaburi and then they moved him. Yeah. But how he got, and I'm not quite sure exactly how he ended up there, but he ended up having multiple surgeries and made a full recovery. And I saw him there maybe a year later, still holding forth at the Bangkok Sanitarium Hospital. So that was pretty amazing. It does bring up one subject, the issue of giving of blood. We've talked about that, and I thought that might be worth talking about our solutions. It had become often enough that one of us on staff would volunteer to give somebody who was desperately ill a unit of blood, that we couldn't keep doing it. And we haven't talked yet about, yes, we did. We talked about the story of the Luang Pa Utamat, with whom we developed warm relationships. And my employee was his friend, Surin, was also my lab tech, and he suggested the idea of working with the Luang Pa to type and cross as many young Mon workers that he would appoint, that he could come over to the hospital and do the type and cross, and have and that way a walking blood bank. And we did that. We had maybe 30 men. Now, they're all men. They're all young men, working men, and the Luang Por just told them that's what they're going to do. So they were quite volunteers of our blood bank, and we used that several times. Depending on their blood type and their availability. But I'm sure you had the same issues of blood supply.
We did, and I don't think we had that same cohort of young men in a walking blood bank, but some of the teachers and some of the people on staff would occasionally be willing to give blood. And then, of course, we always tried to get blood from the patient's relatives if we could. That was sort of the first avenue.
Well, you and I think, Phil, were determined to do as high a quality of medicine as we could.
Yeah.
Given the fact that we were in these isolated situations. I was determined to have X-ray, determined to have as much lab as we could figure, and a good operating system going. And we had this fancy operating table that you lived with as well, that as it aged would no longer hold its hydraulic pump.
That's
so
right.
we would then prop up the table at the proper height.
Slowly sink. And not only that, it would sway a little bit from side to side. The swaying, we never did find a good solution for, but the sinking, we could, because we cut a piece of wood just the right length for each doctor that operated, depending on how high they were and what type of operation they were doing.
And I'm not sure where I got that operating table. It's probably a used one from somewhere else.
Yes, the operating table was definitely a used one. It had a plaque from some hospital in the States. You know.
It's still, I think, important to say that I didn't feel I had to make apology for the quality of medicine that I practiced, nor did you, because we felt the basics we had in tow. We didn't have a lot of the fancy things, and of course, the world has changed since, in terms of the worlds of MRI and CAT scans these days, and all the automated laboratory work. But
you can do so much. I mean, so much good can be done with basic equipment, and in the field of public health with vaccinations and water supply, safe water supply, sewage disposal,